Hi guys, welcome to the image-based session, and this is the first lecture of the entire image-based series where we will discuss the images that have been directly taken from books Nelson and Guy. And these images we will discuss about them, and they have because they have been taken from Nelson and Guy. There are increased chances of them being asked directly in your exams. So we will revise them and we will try to revise them as a story or a case presentation so that it is easier for you to learn and understand about it. So let's begin. Okay, so what is this? The first thing is that this is vaccine, pneumococcal vaccine. So you might all know that a universal immunization schedule has included pneumococcal vaccine, and the pneumococcal vaccine has been included in the UIP. Pneumococcal vaccine has been included in the UIP, and this inclusion in the UIP has included pneumococcal vaccine at 6, 10, and 14 weeks. Okay, and the pneumococcal vaccine that has been included in 6, 10, and 14 weeks are the pneumococcal conjugate vaccine. Pneumococcal conjugate vaccine. Now, there are two types of pneumococcal vaccine, as you might know. One is the pneumococcal polysaccharide vaccine, and second is pneumococcal conjugate vaccine. Now, you have to remember the difference between both of them. That in pneumococcal polysaccharide vaccine, what happens is that you take the polysaccharide structure of the cell wall, and it is used to make the vaccine in the polysaccharide vaccine. While in pneumococcal, you take a protein and you bind this protein to increase the immunogenicity to the polysaccharide vaccine that you have already made. So the difference between pneumococcal conjugate and polysaccharide is that in pneumococcal conjugate there is another protein attached which increases the immunogenicity. So what are the advantages of pneumococcal conjugate or any conjugate vaccine? So first one is it can be used in less than 2 years of age. Polysaccharide vaccines have a very poor immunogenicity, so they cannot be used in less than 2 years of age. While pneumococcal vaccines can be used, the conjugate vaccine can be used. Advantage of conjugate vaccine. So conjugate vaccines can also be used in patients who have age less than 2 years. Second, it has better immunogenicity. Better immunogenicity. Okay, so it has better the conjugate vaccine has better immunogenicity compared to the polysaccharide vaccine, and that is a very big benefit in the pneumococcal or any conjugated vaccine, that it has a better response compared to polysaccharide vaccines. And the dose of pneumococcal is this pneumococcal vaccine, conjugate vaccine, the dosing is 3-dose schedule, and the 3-dose schedule that you have given is 0, 1, and 6 months, like today, tomorrow, and 6 months, if you have not given according to the 6, 10, 14 weeks protocol. Now, this vaccines, PCV vaccines, are pneumococcal conjugate vaccines. PCV vaccines, pneumococcal conjugate vaccines, are available as 7, PCV 7. They can be PCV 10 or they can be PCV 13. While the polysaccharide vaccine is PPV 23. So these are the different variants of pneumococcal vaccines that are used, and Government of India in UIP usually uses PCV 10, which is made by the company Serum Institute of India, and it is also known as Pneumosil. So it is available, but the only disadvantage of PCV10 over PCV13 is that this PCV10 has, less strains that are covered. So due to that, what happens is that these three strains that are unvaccinated, that the child is unvaccinated against, there have been increased prevalence of these variants and strains. So that was one of the concern, but PCV13 is very much more expensive compared to PCV10. So that is why you prefer PCV10, and the mode of administration is intramuscular. Okay, so this is some facts about pneumococcal vaccine. Now, when do we give pneumococcal vaccine? In special conditions. So, in some special condition, we prefer to give pneumococcal vaccine to the patient. Okay, so when do we give the patient pneumococcal vaccine if he has not taken it? So, uh, we give the patient when the patient is suffering from chronic heart disease or a congenital heart disease or a chronic lung disease. Now, these have increased chances of endocarditis and increased chances of pneumonia. All the chronic diseases will decrease the immunity. They will decrease the immunity and the fighting power of the patient to the infection. So that is why you always have to give these patients the vaccine if they have not already been vaccinated. The vaccine was given in UIP just a couple of years before. So, the patients who are more than 5, 6, 7 years, they have not got this as a part of universal immunization program. Diabetes mellitus, CSF leak, again, the most common cause of meningitis in pediatric population is pneumococcus, streptococcus pneumoniae. So cerebrospinal fluid leak has increased chances. Then when you give a cochlear implant, now there have been questions that which is the most common cause of meningitis causing hearing loss. Now, as you know, one of the complications of meningitis causing hearing loss, it is sensory neural hearing loss. What happens is the sensory neural hearing loss was historically caused by the infection of Haemophilus influenza. But now, with Streptococcus being the most predominant organism to cause meningitis, it has become the most common cause which causes the issue to the patient. Yeah, so we will be having, the now that with Streptococcus being the most common cause causing all the issues and the complications of meningitis, it has to be given to the patients whom you are planning cochlear implant. Sickle cell disease and other hemoglobinopathy, as you know, sickle cell disease is a phenomenon known as autosplenectomy, or even the other hemoglobinopathy. If you plan that you want to do splenectomy as a treatment protocol for the patient, then you have to give vaccination with three primary vaccines that I want you to remember. One is streptococcus, other is hemophilus, though hemophilus is now part of the pentavalent vaccines, and the third vaccine that I want you to remember is meningococcal. Also, one more vaccine, extra vaccine that I would like you to recommend is hepatitis A. So these four vaccines you have to give in patients of hemoglobinopathy. Then in patients who have functional asplenia, or they have hyposplenia or asplenia, either it might be functional or it might be structural, any cause, you have to give the patient. HIV infection, again, very important. There are increased chances of opportunistic infection. So you have to remember that in HIV infection, you have to give the patient a vaccine. Nephrotic syndrome. Why is it important to give pneumococcal vaccine in nephrotic syndrome? Is there are increased chances of spontaneous bacterial peritonitis. And this bacterial peritonitis, the most common organism is pneumococcal, followed by Staphylococcus aureus. So peritonitis is very common in patients of nephrotic syndrome, and to prevent them and to decrease the complications, we have to give all the patients of nephrotic syndrome vaccination with pneumococcal vaccine. Then neoplasms who are who are under either immunosuppressive therapy, or they might be under the regime radiotherapy or chemotherapy. So them you have to give Then when you give solid organ transplantation, again, you are planning to give the patient long-term immunosuppressive therapy. So you have to give the patient uh, a dose of pneumococcal vaccine. Now, these are the important images 1, 2, 3, 4, 5, 6, and these might be asked as this considering this temperature. This is temperature versus time graph, and as you see that in here, these are the patterns of fever. Okay, so these are the patterns of fever. Here, what's happening in the image number 1? The fever is being consistent. There are not huge fall down and fall peaks. So this fever is generally consistent. It is not falling up and falling down, and the falling up and falling down is not more than 1.5 degrees Celsius. So that is important, and that is the definition of continuous type of fever. Now, there is another type of fever where there are multiple spikes in a day, but the fall of temperature is again here. See, here you might see that there is a 39.5 degrees Celsius, and here, the baseline is not reached, but the variance is more than 1.5. So there is continuous form of wave. There is fever is continuously present entire throughout the day, but what happens is the fluctuations are high, but the child has fever the entire day. So there are high fluctuations, but there is no normalization of temperature. Fever is there throughout the day. So that is what we call it as a remittent fever. Now, in one pattern of fever, there are multiple spikes in a day, but there also is normalization of temperature at some period of the day, and that is known as intermittent fever. Now, there are other 3 specific patterns in which there are different fevers. So if the fever spikes twice a day, it is called as biphasic fever, and biphasic fever is usually seen with multiple viral diseases, including dengue fever. Recurrent fever is the fever that occurs multiple times a day with small spikes in between, while undulating fever is also known as the high grade undulating fever that occurs during majority of periods. See, this is not a definition, this is just a type, but I want you to remember this 1, this 2, this 3, this 4, and this 5. These patterns might be asked directly that, okay, what are these, which type of fever or which disease might cause this fever. So we'll get into diseases. So intermittent fever is multiple spikes. There are multiple spikes during the day with normalization at least once. Normalization of fever with normalization of temperature at least once a day. So at least once a day, the temperature gets normalized and there are multiple fever spikes. Intermittent fever is, seen with multiple causes like viral fever or sepsis, or even the malaria. Malaria has multiple forms of intermittent fever that we see. Sustained fever is also known as continuous fever. And here there is fever throughout the day. The entire day you have fever, and the variation of the temperature does not occur more than 0.5 degrees Celsius every day. Now, if the fever is present throughout the day, but the variations are more than 0.5 degrees Celsius, it is known as a remittent fever. Remittent fever is a weaker version. See, this is the entire spectrum. The continuous fever is the most severe, then the remittent fever, and then the intermittent fever. So this is an entire spectrum. And then there are variants of remittent and relapsing fever. And this relapsing fever are fever with febrile periods with normal temperature in between. Now, what is the tertian fever known as tertian fever? So tertian fever is fever that occurs on the gap of 24 hours. So there is a fever on the first day, then second day there is no fever. There is a gap of 24 to 48 hours, and then again there is fever. So first day there is fever, then the second day there is no fever, then on third day there is fever. So that is caused by Plasmodium vivax, which causes a disease known as benign tertian malaria. Benign tertian malaria is caused by Plasmodium vivax, while quartan fever is caused by Plasmodium malaria, where fever occurs on the first day, then 2 days there is no fever, and then on the fourth day there is again fever. So this is benign quartan fever. Benign quartan fever. And the Plasmodium falciparum causes a variant of continuous fever. So it is a malignant tertian fever or a malignant continuous fever. So that you have to remember. Then there is something we saw as biphasic fever, where there occurs two fever spikes are there in a day. And the classic example of biphasic fever is polio, but it is historically been seen very, very commonly in dengue fever in India. And it is known as camelback fever or humpback fever. And that fever is, one of the common example in India is dengue fever. It causes bifever, 2 spikes in a day. Periodic fever are fever syndromes where there occur cycles of fever going up and going down, and it might be caused by diseases like cyclical neutropenia or periodic fever syndromes, or manipulation by factitious fever or self-induced fever. Manipulation of the thermometer might be there. Now, double quotidian fever is again the fever that peaks twice in 24 hours. Quotidian fever is fever that peaks once a day, and double quotidian is peaks twice a day, and it is historically been associated with inflammatory arthritis. So I hope you understood the fever patterns and you will remember this. Now, this X-ray, very, very important here that, when you get an X-ray of a patient, then what is the first approach that you do? Now, here, the X-ray is abnormal, that you can see that between the left-sided lung field and the right-sided lung field, there is some abnormality. Now, in the right side, what do you see is there are something, the areas of air-filled spaces. See, these are air-filled spaces in between of whitish consolidation. So here what is happening is that here there is some degree of consolidation. This whiteness is some degree of consolidation, and there is some degree of pneumonia present. So pneumonia is present, and this pattern of pneumonia is severe pneumonia. It is a pattern of lobar pneumonia. It might be it is not a pattern that we see in bronchopneumonia. Also, there is obliteration of CP angle, so there is an evidence of pleural effusion. So there is a pleural effusion over here, and there is consolidation present with some areas of air. Now, I will give you a case that how did this patient come to you. So this patient came to you with complaint of high-grade fever since 7 days. And when you auscultated, that was the only complaint, that the patient had high-grade fever. And when you auscultated the patient, you saw that air entry on the right side was absolutely absent. Now, you went for an X-ray and you saw that there is massive pleural effusion and there is massive consolidation. And in between, you see these black areas which are known as pneumatocele. Now, what is a pneumatocele? Pneumatocele is a area or a abscess-like area, air-filled area in between of a consolidated or a effusion present in the lung, and this pneumatocele is a hallmark of staphylococcal pneumonia. So this pneumatocele is the hallmark of Staphylococcus aureus infection. The presence of pneumatocele, the presence of bullas. See, this can be also said as bullas. See, pneumatocele and bullas are ideally the same. It is just the size difference. And there is effusion. So, pneumatocele and bulla when present in the lungs. See, here also there is some. There are multiple pneumatoceles present over here. And this is the hallmark of Staphylococcus aureus pneumonia. Also, there is a dictum in pediatric patient that if a pediatric patient has pleural effusion if pediatric patient has effusion, then it is due to staphylococcus unless proven otherwise. So a pediatric patient with pleural effusion has a staphylococcus infection unless proven otherwise. So you can understand that how common is presence of pleural effusion in an infection with staphylococcus, and how commonly staphylococcus causes pleural effusion. Again, this dictum was made by developed countries, so they have not considered the presence of tuberculosis. But taking apart tuberculosis, the most common cause of pleural effusion or a massive pleural effusion or a pyothorax or presence of nematocele and bulla essentially seals the diagnosis of staphylococcus aureus. There are other two variants of staphylococcus that I want you to remember is toxic shock syndrome and staphylococcal scalded skin syndrome. These two are commonly associated with the pentanvalentine leukocidine, and this toxic shock syndrome may present with septic shock, while staphylococcal scalded skin syndrome is present with the skin involvement, and frequently these might turn out to be MRSA, where you will have to give the patient vancomycin. Now, another important thing is when you have a patient of staphylococcal pneumonia and you have isolated the patient, and it shows that there is vancomycin resistant Staphylococcus aureus. So you have a vancomycin or a VRSA organism causing pneumonia in the patient. Now you decide to give daptomycin as the drug of choice, because all of you know that daptomycin is the drug of choice. Daptomycin is the drug of choice. Is drug of choice for VRSA. Okay, linezolid is not the drug of choice for VRSA. Daptomycin is the drug of choice for VRSA, and you choose to give daptomycin in these patients. But you have to remember that though daptomycin is the drug of choice for VRSA, daptomycin is a surfactant antagonist. So in a patient with respiratory infection with VRSA, the drug of choice is linezolid. Rest entire body, if you have infection with VRSA, daptomycin is the drug of choice, because daptomycin antagonizes surfactant, and that is one of the common complications that you will find with daptomycin. So for respiratory infection, you give linezolid, you do not give daptomycin, while for non-respiratory infection, you give daptomycin. Now, as you know that staphylococcus generally can cause infection anywhere, and it is more common with cystic fibrosis and defects in leukocyte function. I want you to remember that cystic fibrosis, there is mucociliary impairment, mucociliary function impairment. So what happens is there are recurrent infections. So which are the most common organism causing infection? Organism causing infection or pneumonia in a patient with cystic fibrosis. So in pre-pubertal or pre-adolescent or pediatric population, the most common cause of respiratory infection in cystic fibrosis is Staph aureus. It is not Burkholderia. Burkholderia is a specific infection. It is not the most common infection in the patients with cystic fibrosis, and the most common organism is Staphylococcus, while the most common in adolescent or in adult population, it is a Pseudomonas. So in earlier years in pediatric population, the most common organism to cause pneumonia in patients of cystic fibrosis is Staphylococcus aureus, while in adolescent or even in the adult, the most common organism is Pseudomonas. Burkholderia cepacia complex is a common infection, but it is not the most common organism to cause pneumonia in patients with cystic fibrosis. Now, sometimes with Staphylococcus aureus, you have presence of tracheitis, and tracheitis will cause Haemophilus influenza like laryngitis syndrome, and early institution of antibiotic therapy is required, or else the patient, deteriorates further. Right-sided endocarditis, the most common cause of endocarditis is overall Staphylococcus aureus. Staphylococcus aureus is a very common cause when you have a device or a central line present. Also, the cones is also coagulase negative. Staphylococcus are also common cause to cause, they are intravenous drug users. Then they are commonly causing endocarditis. But overall, if you see, the most common cause of endocarditis in a patient with uh, endocarditis, the most common cause of endocarditis in no valvular disease or no risk factors, it is Staphylococcus aureus. Now, here we have a patient, a boy that came to you with the history that, on the second and third day of illness, he has presence of this type of rash over the body. There is presence of fever, and the tongue on the second day is something like the image seen in B. And on the fourth day, the image is something like you see in the C. So you have a patient with fever with rash. Okay, so for fever with rash, you have to consider that if the child has, the systemic involvement, and the rash is, as you can see, maculopapular variant. Here you can see in the image that the rash is maculopapular, and in maculopapular rash, what are the differential diagnoses in a patient who has fever with rash in a pediatric population? So first you might think that there is a presence of Kawasaki's disease. But what is the problem with Kawasaki's disease is that Kawasaki's disease is usually seen in children less than 5 years. And here you can see evidently that the child is more than 5 years of age. Kawasaki's disease is commonly caused in children less than 5 years. Again, it might cause in any children, but commonly it is caused in more younger children. 4 to 6 years is commonly, but this child is evidently older than that age. Second diagnosis, you can see that it might be scarlet fever. So here in the tongue, if you can see very carefully, you will see there is something which we call as strawberry tongue. This is a strawberry, and the dots of strawberry are there over here. So this is a strawberry tongue, and this is a hallmark strawberry tongue. This first image is a white strawberry tongue, and the second image is red strawberry tongue. Now you might have been told that Kawasaki's is associated with white strawberry, scarlet is associated with red strawberry. That is false. Both can occur with both. So you cannot say that red strawberry tongue is seen in X condition and red strawberry tongue is not seen in the Y condition. So that you have to be very, very careful in labeling, that both can be seen with both, and you cannot label the patient like that. Now, this image is of scarlet fever, where I told you that the maculopapular erythematous infection that you see, maculopapular erythematous eruption that you see of the skin, and these are present all over the body, and they are accentuated in the creases of elbows, axilla, and groin, and those are called as Pastia's line. These Pastia's lines are pathognomonic for scarlet fever, and they are not seen with any other condition. Now, after 3 or 4 days, the rash begins to fade. And there is presence of desquamation. This desquamation can also be present with Kawasaki's disease, and desquamation is essentially seen commonly in these two conditions, Kawasaki's disease and scarlet fever. And technically, it is very difficult to differentiate Kawasaki's disease with scarlet fever. And you usually have to go for presence of echocardiography and presence of group A beta hemolytic streptococcus on pharyngeal culture. If this is present, then you can go towards either that. If coronary artery findings are present, you can tell that it might be Kawasaki's. And if group A beta hemolytic streptococcus is isolated from the throat, then you can say that it might be scarlet fever. And as I showed you the image, white and red strawberry tongue, these are both present in scarlet fever. And you cannot say that one is not present in scarlet fever. Both can be present in a patient with scarlet fever. And as you know, scarlet fever is caused by group A beta hemolytic streptococcus. What are the other complications of group A beta hemolytic streptococcus are the first complication is rheumatic fever. As you know, rheumatic fever, Sydenham chorea, that all, then it might be PIGN, post-infectious glomerulonephritis, PIGN or PSGN. Third complications is PANDAS, pediatric associated neuropsychiatric disorders associated with streptococcus. So these are PANDAS, and these might be associated with streptococcus, and this have been thought to be associated with streptococcus. And fourth is PRESS, pediatric reversible, posterior fossa posterior reversible encephalopathy syndrome, or a PRESS syndrome, that is associated commonly with streptococcus infection, and it might cause a patient to get convulsions, and there might be presence of hypertension also in this patient. So these are the few things that I want you to remember with streptococcus infection. This now this here, you what do you see, that there is a child who comes to you with complaint of fever and this type of rash, which might be predominant in the areas around the lips. And here what you see is honey colored or amber colored crusting lesion, honey colored crusting lesion. And wherever you see or find honey colored crust, then it is always presence of impetigo. So this is the image of an impetigo, and impetigo is always, this words honey colored or amber colored crusting lesions are always associated with impetigo. Now, impetigo are essentially of two types. One is non-bullous impetigo and one is bullous impetigo. So non-bullous impetigo is associated with superficial infection, and the photo that we saw was ideally non-bullous impetigo, and there are presence of papillovascular lesions, and they might become purulent, and they are amber colored crust are present, and there are local areas of involvement of redness. Now, non-bullous impetigo, the most common cause of non-bullous impetigo is not streptococcus, it is staphylococcus. And after staphylococcus, the most common cause is streptococcus. This is what Nelson says, that the most common cause of non-bullous impetigo is staphylococcus, and the second most common cause of non-bullous impetigo is streptococcus. There are multiple other bacterial infection which may cause this issue, but these are most commonly associated with staphylococcus. Now, bullous impetigo, you see presence of flaccid bullas along with the impetigo that we saw. And here in bullous impetigo, it is always and always staphylococcus infection. Bullous impetigo is always been caused by staphylococcus, while in non-bullous impetigo, streptococcus might be present in some patients, but in bullous impetigo, the cause is staphylococcus aureus, and that you have to remember. You can give treatment as mupirocin ointment, but after impetigo, you have to remember that post-infectious glomerulonephritis can be seen after 4 to 6 weeks of impetigo infection, while rheumatic fever is never seen after the occurrence of impetigo. Now here we see a rash. Now what is this rash? This is a snake-like, if you can see, see this rash is, a targetoid rash. This is a targetoid rash. And these are snake-shaped serpiginous rash. Snake-shaped serpiginous rash, and this is associated with rheumatic fever. So this is associated with polycyclic pattern of erythema marginatum that is seen in a patient with acute rheumatic fever, and it is a characteristic rash of rheumatic fever, and it is not seen with any other condition. It is characteristic rash of rheumatic fever. Now, what are the major criteria of rheumatic fever? So, what are the major criteria of rheumatic fever? First is polyarthritis, which is migratory in nature, arthritis, polyarthritis. Then second is pancarditis. There is presence of pancarditis or carditis. Then what is the third feature that we see? That we see is migratory where is erythema marginatum. Erythema marginatum, or the rash that we see in the image, erythema marginatum. Then what is the fourth finding? You can see subcutaneous nodules. Subcutaneous nodules are most prominent in extensor region, and they are hard, non-painless subcutaneous nodules which shift from organ to organ. And the final part is Sydenheim scoria or CNS involvement. So these are the five major criteria of rheumatic fever, and here you have to remember that this erythema marginatum is increased by hot bath or hot water or hot temperature, and it is decreased by cold temperatures. Like if you put the ice, the rash will disappear. So it is temperature sensitive rash, erythema marginatum, and it is pathognomonic for or characteristic for rheumatic fever. Minor criteria for rheumatic fever is arthralgia or polyarthralgia, ECG abnormalities. Then there might be presence of increase in CRP or increase in inflammatory markers. So all these are the minor criteria present for the diagnosis of rheumatic fever. And what are the mandatory criteria, or which are the essential criteria, is presence of ASO titer more than 333 in pediatric population, or isolation of group beta hemolytic streptococcus from the throat. So if the organism has been isolated, then it is antecedent or the confirmatory or the required criteria that you have to isolate streptococcus from anywhere. Now, here in this image, you see a patient with difficulty in breathing. There is presence of stridor, and you see this area of neck has been swollen. So this is known as a bull neck. Bull neck. The neck is like a bull, and this is due to severe submandibular adenopathy, lymphadenopathy. It is due to lymphadenopathy. Severe, lymphadenopathy is present in this patient, and this is commonly associated with diphtheria infection, though it might be associated with any infection. This is essentially an adenopathy. It is historically been called bull neck when it is associated with diphtheria. Now, in diphtheria, you have to remember that there is most common is nasal diphtheria, and anterior nares are most commonly involved. And in tonsillar and pharyngeal diphtheria, sore throat might be the only feature that you see. Now, in diphtheria, as you know, there is presence of pseudomembrane formation, and this is toxin-mediated pseudomembranous formation. And again, if you pull the pseudomembrane, there is bleeding, there is presence of bleeding. So that is how you differentiate pseudomembrane with other types of membrane. And there is a soft tissue edema and enlarged lymph nodes, which causes bull neck appearance, as you saw. Now, how do you differentiate between the presence, the other cause of pseudomembrane is, see, firstly, your differential diagnosis is Lemierre syndrome. What is Lemierre syndrome? It is jugular venous thrombophlebitis. Jugular venous thrombophlebitis. And it causes a swollen neck. There is a swollen neck. There is jugular venous thrombophlebitis, and it is commonly caused by a bacteria known as Fusobacter necrophorum. The most common cause of Lemierre syndrome is Fusobacterium necrophorum, which causes jugular venous thrombophlebitis, and it causes unilateral swelling of the neck. The other differential diagnosis is infectious mononucleosis caused by Epstein-Barr virus, and there is associated generalized lymphadenopathy. Here there is generalized lymphadenopathy with hepatosplenomegaly. There is also pseudomembrane formation in infectious mononucleosis, but it is associated with hepatosplenomegaly and generalized lymphadenopathy. And streptococcus may also cause presence of a pseudomembrane presence, but the patient is extremely toxic. Each patient with streptococcus pseudomembrane, and you always have to rule out the bacterial infections when compared to viral infection. Now here in this image, you can see the presence of, there is a rash present, and this is erythematous rash, and it seems like there has been subcutaneous bleeding over here. So this is historically seen in platelet pattern of breathing, platelet disorders. And how do you differentiate between if there is a platelet disorder, platelet based bleeding, versus if there is a bleeding of absence of coagulation pathway? So if there are absence of factors in coagulation pathway, the most common bleed present is either hemarthrosis or a muscle bleed. They are usually deep tissue bleed. While in platelet pattern of bleeding or platelet dysfunction pattern of bleeding, the skin is the most commonly involved, and it is subcutaneous bleeds that you commonly see on the skin. So this seems to be like a platelet pattern of breathing, and when it is associated with meningitis, when the patient has the feature of meningitis, when the patient has feature of sepsis, and when the patient presents to you with shock, you always suspect the presence of meningococcemia. So meningococcemia is caused by gram-negative coccus, meningococcus, and it causes meningococcemia, and it causes a syndrome known as Waterhouse-Friderichsen syndrome, where what occurs is that it causes adrenal abnormality, adrenal hemorrhage. Waterhouse-Friderichsen, it causes adrenal hemorrhage. So it causes shock-like Addisonian features due to adrenal hemorrhage, and there is presence of sepsis because meningococcemia is gram-negative sepsis due to endotoxin, and might also be presence of meningitis in this patient. So in a patient of meningococcemia, there might be presence of abnormal skin color initially, because there is endotoxinemia. This occurs due to endotoxinemia, and it begins as a non-blanching petechial rash. And as we saw in the photo, there is a fulminant meningococcemia where the disease progresses in few hours to full-blown sepsis, and it is known as purpura fulminans. The photo that we saw was purpura fulminans, and there is presence of poor perfusion, tachycardia, which are the signs of shock, hypotension, confusion, coma, and these all are signs of shock. Now you have to remember that prophylaxis of meningococcemia is done by a drug known as rifampicin. It is done by rifampicin, while treatment is ideally preferred with IV ceftriaxone, and you can also give IV drugs, other drugs like meropenem and everything. But the first line drug for prophylaxis is rifampicin, oral rifampicin, while the treatment is either done by ceftriaxone, and if it is a newborn, you give cefotaxime because ceftriaxone itself causes neonatal jaundice. So you have to remember that ceftriaxone is the drug of choice, while rifampicin is used for prophylaxis in contacts of patients with meningococcemia. And another one-liner I want you to remember is that the B serotype, is not covered by meningococcal vaccine. Meningococcal conjugate vaccine does not cover the B serotype, and this B serotype causes the most fulminant, most dangerous disease, and this is associated with huge endemics. See, meningococcemia is associated with huge endemics of meningitis because it is very, very easily spread by the aerosol route. And you will have patients, who have gone. Typically, it has been said that the patients who go on Hajj. So, if one patient is involved, there are close clustering of so many cases in patient because there is no in this group where there are multiple groups, there is no safety distance maintained, and there is the local area endemics can be seen in patients with meningococcemia. Now here, this is a very poor image, but this poor image shows the presence of rose spots in the patients of enteric fever. These rose spots are seen in patients of enteric fever in the second week of illness, and these are macular or maculopapular rash present on 7th or 10th day of illness, second week of the illness, and they occur in crops in the lower abdomen usually, and they are missed in dark skinned children. You have to remember that in enteric fever or in typhoid fever in the first week, the investigation of choice for diagnosis is blood culture. Vidal test is always negative in the first week. In second week, Vidal test might be positive, so you can go for Vidal test. So you have to remember that in first week of illness, the first week of illness, you do not go for Vidal test. You go for blood culture. If the patient is not affording, then obviously there is no point of Vidal test, because Vidal test is actually the antibody test, and antibody takes time to form. So Vidal test will be negative in the first week of the disease in the enteric fever. Now this image shows us either this is something, we don't know what this is, but I will tell you that this is stool sample. So this stool sample shows us the typical rice water pattern. And as you know, rice water stool are seen with cholera. So cholera are usually, majority of the patients are mild and inapparent, but in some patients there is a manifestation known as cholera gravis. Now, this cholera gravis causes, see, with cholera, you will have a history that the patient has only, like patient had multiple episodes of diarrhea at night, and morning the patient will present to you with severe dehydration, and they will tell that, oh no, doctor, we have been giving ORS the entire night, yet the patients of cholera come to you with severe dehydration. So a dehydration that is, a very acute onset, and which is in not proportion with the loose stools. Like they'll tell you, we have only had episodes of 4 or 5 episodes of foul smelling stools, but only 4 or 5 episodes, but the child has gone into shock. So due to 4 or 5 episodes of shock, you will expect the child not to go in shock. There might be mild or some dehydration. But here in cholera, you will have foul smelling few episodes, which will cause the patient to go into shock. We have had clustering of patients of cholera because, again, it is transferred from fecal-oral route, and patients will have profuse watery, foul smelling rice water type diarrhea, and they will just, they are projectile. Like the patient will have continuous projectile flecks of mucus are present with a fishy smell, and it is very foul smelling. That is the hallmark of disease. Now, the drug of choice, again, for pediatric patient, you can go for azithromycin, but the drug of choice has been told by the WHO as drug of choice is doxycycline. And in adults, they usually, drug of choice is not azithromycin. Azithromycin is second line. The drug of choice is doxycycline. But we prefer azithromycin because it has lesser side effects and it is safer in children. And in adult, they are also using fluoroquinolones. But nowadays, fluoroquinolone resistance is growing. And the investigation that you go for in patients with cholera is darting motility. And if you do not write darting motility of stool, they will not see for it. And the transport media is Venkat Raman Ramakrishnam medium. And this is an alkaline type of bacteria. And there is another cholera bacteria known as Vibrio parahemolyticus, which shows something known as Kanagawa phenomenon. Now, here we see a necrotic ulcer present in the dependent or the gluteal area of the patient. This is extremely necrotic red ulcer present. And when I tell you that this child has presence of immunodeficiency, a necrotic ulcer in an immunodeficient child, you always have to understand the diagnosis of ecthema gangrenosum. Ecthema gangrenosum. So that would be the diagnosis of ecthema gangrenosum. And you have to remember that in a patient with immunodeficient, if there is a necrotic ulcer, the diagnosis is usually ecthema gangrenosum, where there is a eschar formation. Eschar is the black colored necrotic area surrounded by a red inflammation. And it is also associated with rickettsial pox and the rickettsial infection. Eschars are also formed with rickettsial inflammation, and they are black colored lesion. And this ecdyma gangrenosum is commonly present in immunodeficient patient. And the most common cause of this is Pseudomonas aeruginosa. Though it might be caused by any bacterium, The Pseudomonas aeruginosa is the most common organism causing eczema gangrenosum in immunodeficient patient, and it is usually associated with green-blue pus and fulminant sepsis. There might be fulminant sepsis. So, fulminant sepsis in an immunodeficient patient with this necrosis, then you might suspect it to be eczema gangrenosum, and commonly it is seen with Pseudomonas aeruginosa. For Pseudomonas aeruginosa, you either have to give piperacillin tazobactam or cefoperazone sulbactam, because cefoperazone, ceftriaxone does not cover Pseudomonas. So you have to be very careful that you have to either give cefoperazone or you have to give ceftazidime. The third generation cephalosporin that are anti-Pseudomonas are cefoperazone and ceftazidime. Ceftazidime. So these two anti-Pseudomonas drugs, you can also give piperacillin tazobactam. And usually the drug of choice is third generation cephalosporin or piptas plus aminoglycoside. So combination of these two drugs are usually given in patients of Pseudomonas infection. And Pseudomonas infections are usually very fast spreading, and in immunodeficient or in cystic fibrosis, they will lead to sudden onset, involvement of the entire body. And nowadays, as you know, Burkholderia, Pseudomulli and Mulli and Burkholderia cepacia are included in the Pseudomonas criteria, and now they are called as Pseudomonas mulli and Pseudomonas pseudomulli. So you have to remember this, that these organisms have now been classified under Pseudomonas banner. Now this here you see unilateral conjunctivitis. Here you see unilateral conjunctivitis. And this unilateral conjunctivitis is present in this pediatric patient, and there is association of, there was a history of, a child getting scratched from a cat. The child has a history of getting scratched from the cat, and there is a unilateral conjunctivitis, and there is granulomatous folliculitis, and history of getting scratched with a cat. Granulomatous folliculitis, and then there is axillary lymphadenopathy. So this is the disease that we know as Parinaud's oculoglandular syndrome, which occurs with cat scratch disease. Parinaud's oculoglandular syndrome is unilateral conjunctivitis with granulomatous folliculitis with ipsilateral lymphadenopathy. That is Parinaud syndrome, which is associated with multiple infections like cat scratch or tularemia or sporotrichosis or tuberculosis. But the most common cause of Parinaud oculoglandular syndrome is cat scratch disease, or also it is caused by Bartonella henselae, which causes necrotic stellate granulomatous infection. So Bartonella henselae is the most common cause of Parinaud syndrome, though Parinaud may occur with association of tularemia, sporotrichosis, tuberculosis, syphilis, everything, but the most common cause is cat scratch disease. Cat scratch disease is a self-limiting infection, and it is associated with Parinaud's oculoglandular syndrome, where there is unilateral conjunctivitis and lymphadenopathy might be seen. This lymphadenopathy, there might be associated granuloma, which is necrotic stellate granuloma. Necrotic stellate granuloma. And it is associated with unilateral lymphadenopathy, submandibular or cervical lymphadenopathy might be seen. So that is about a cat scratch disease or Bartonella henselae. Now, this newborn presents to you with no known maternal history, and mother has no history of tetanus shots during the pregnancy. And this patient comes to you at day of life 4 with, the child gets spasms, multiple spasms, which are prominent on voice stimulation or large voice stimulation or touch. the child is not feeding and the child is having continuous spasm with frothing of the mouth and the shape, the face that you see, and the mother has no history of tetanus injection and the delivery was home delivery, and there were no cut or clean cords. So here we have a disease of neonatal tetanus. Neonatal tetanus has been eliminated in the developed countries due to the cleans that we use, the clean cord, clean blade to cut the cord, the clean clip that we use, so and the clean hands we use to do the delivery. So if you keep everything clean, then tetanus does not occur. But nowadays, if you do not take the injection with tetanus or the tetanus shot, that is along with DT. DT is given during pregnancy. Two doses are given. If the previous delivery was within 3 years, then you give single dose. So that you have to remember that you give tetanus. Tetanus is a very easily vaccine preventable disease, and in neonatal tetanus, mortality is 70 to 90% of the patients die, because this is a very severe disease. You have to give immunoglobulin, tetanus immunoglobulin in this patient along with tetanus vaccination and penicillin, and you have to sedate the patient with benzodiazepines, because if you do not sedate the patient will have continuous spasm. Now the antitoxin that you give binds to the free toxin, but the toxin that has been already functioning or that has already bound to tetanospasmin, this tetanospasmin that has been bound already to the spinal cord, that cannot be stopped by the immunoglobulin. So until that period where passes, that those toxin, tetanospasmin gets uh, disattached with the spinal cord, until then you have to keep the patient stable. The role of IVIG is to neutralize the free toxin. The role of antibiotics is to decrease the bacterial load, to kill the bacteria so that they do not produce more toxins anymore. And you have to keep the patient stable until the bound toxin is, the half-life of the bound toxin is over and the bound toxin detaches itself and the patient can improve on their own. That's all for today, guys. And next lecture, we'll see the mycobacterial disease, the viral disease, the fungal disease. And with these, we have to keep in mind that image-based questions are now being very important in the NEET PG. So I hope you learned something new today. I'll see you in the next lecture.